Okay, we're going to get started. Good morning, everyone. My name is Sherry Rubin, and I'm the healthcare coordinator at the Bucks County Drug and Alcohol Commission. I'd like to welcome everyone here today and thank you for attending this very timely webinar on stigma as it relates to outcomes for individuals with substance use disorders. I say that this webinar is timely because, as I'm sure you all know, over 93,000 people died of overdose in the United States in 2020. And that was about a 30% increase from 2019. Here in Bucks, we saw about a 16% increase. So today, we're going to hear about ways that we can all positively impact the numbers and impact people's lives. So I have a few housekeeping items that I need to go over first, and then I'll introduce our speakers and we can begin the presentations. So first of all, if you're watching in a group with others and you did not connect to the webinar with the link that you were sent, please make sure to put your name, email address, credentials, and your work affiliation into the chat box. Also, if your full name did not appear when you logged in, please also enter that information in the chat. So this is the only way that we'll know that you're in attendance. And that's important for both continuing education credits and also because BCHIP is providing a $15 Wawa gift card to any staff who attends from the hospital with the most attendance. So you'll also notice that everybody has been muted for this presentation. If you have questions for our speakers, which we hope you will, we encourage you to put them in the chat box, and then we'll save those questions for our Q&A period. You will also be able to unmute yourself to ask a question when we're in the Q&A session. So now I have some information regarding continuing education credits and evaluations. So if you are seeking nursing credits, please make sure to read the information that's on the screen right now. Following this presentation, all attendees will receive an evaluation via email. And we ask that everybody complete that evaluation. At the bottom of the evaluation, you can indicate if you need either a certificate of attendance, NASW credits, or nursing credits. Once you submit this evaluation, you'll receive an email with a link to the CE evaluations. And we're asking that you please complete all of the evaluations within 10 days of this webinar. While there's no charge for the nursing credits, just note that the cost for NASW credits is $15 for members and $25 for non-members. And you must attend the entire presentation to receive continuing education credits. So we have two speakers this morning. Dr. Sean Fogler is a physician living in long-term recovery and a co-founder and consultant with Elevist, a public health consulting group. Dr. Fogler works extensively with healthcare systems, law enforcement, and community-based organizations as a public health security and drug policy expert. He uses his lived experience to educate and inform, reduce stigma, and improve public health policy for mental health and substance use disorder. Dr. Bonnie Milas is a clinical professor of anesthesiology and critical care medicine at the University of Pennsylvania. She is painfully aware as she has lost both of her sons to this disease. She's an outspoken advocate for those suffering from opioid use disorder. Dr. Milas has published opinion pieces in the Philadelphia Inquirer and USA Today in an effort to reduce social stigma. Through her work locally with the Bucks County Drug and Alcohol Commission and nationally with the American Society of Anesthesiologists, she is an ardent educator of Naloxone overdose rescue. Dr. Milas is the Chief Narcan Rescue Officer at her institution. So with that, I'm going to turn this over to Dr. Fogler to begin the presentations.
Thanks so much, Sherry. Let me just share here. Okay, can everybody see my screen?
Yes.
All right, excellent. First, I'd like to thank the Bucks County Drug and Alcohol Commission for hosting this important event. As Sherry said, it's very timely. Also like to thank Sherry and Mallory for all their hard work on this, and especially Bethany for the technical issues this morning. We're in a Zoom world. So this is me, and Sherry already gave my introduction, but today we're going to talk about stigma and some action steps to reduce stigma and improve care. But before we do that, I'm going to give a brief primer on drug policy, because I think it's hard to talk about stigma, which is a very complex subject in itself, without really looking at historic drug policy. And this will be quick up front, and then we'll talk about stigma, why it's important, the consequences of stigma, and some research that I've been doing over the past year. So there's so many problems and so many intersections, which makes it very complex. And at a really high level, if we look at the overdose crisis, we look at mental health challenges, and those intersections with the criminal justice system, communicable disease, and so many other issues. This is really complex and really challenging, and this crisis has so many different angles to it. And one of the big problems is that, historically, we've criminalized this disease. And we've criminalized many of the strategies, effective strategies to address this disease. And people like to point their finger at the criminal justice system, and there's many issues there that we could discuss. But many of those policies and practices have been embedded in other institutions, like our healthcare institutions. And unless we really get under it and look at the root causes of the behaviors, and the different systems that impact those behaviors, will never really make progress. And I put stigma over here in red, and I really should have, put a cloud, because stigma covers all of this. The perceptions and attitudes that we have towards people that are using drugs, that are struggling with disease, have impacted our policies, which impact our ability to care for these people in an effective way. And I'm one of these people. I myself, struggle with a substance use disorder, which was rooted in trauma. And it can be really challenging to push through, these different systems. And so we're going to talk a bit about that today. And just some history, it's been, 60 years since the single convention on narcotic drugs was kind of enacted, and nobody really talks about this, but this was an international treaty that aimed to reduce drug consumption around the world. And it's really interesting because, in the document that was, created from this convention, in the preamble, it states that the parties are concerned with the health and welfare of mankind. Obviously, it was in the 60s, and are conscious of their duty to prevent and combat the evil of drug addiction. And the interesting thing is that the two main focus areas of this treaty were to limit the possession, distribution and manufacture of drugs unless they're used for medical use, and combat drug trafficking. There was nothing about dealing with the disease of addiction, supporting people in recovery, harm reduction, so many other different things. It was strictly focused on supply, and along came, Richard Nixon 10 years later. And that past treaty, the Single Convention on Narcotics, really covered or colored, our entire approach to addressing drug use around the world. And 10 years later, Richard Nixon came along and declared, drug abuse America's public enemy #1. We need to fight and defeat this enemy. It is necessary to wage a new all-out offensive. And this was the impetus for the drug war, right? And the drug war is a war on people. And the reality is this started long before Nixon came along, and long before the last treaty that I was discussing. The 1870s, 1900s, anti-opium laws around the Chinese, the blacks, were associated with, anti-cocaine laws. anti-marijuana laws. So we use these laws to control groups and oppress people and marginalize them, and much of the policy after that was really colored by that. And, in 1980, the annual federal expenditure on drug law enforcement was about $8 million. Today, it's over 35 billion. The interesting thing is that, early on, that money was strictly directed towards supply side strategies. Today, it has started to shift, and I would say it's more of a 50-50 split towards, prevention, intervention, recovery supports, all the things that we know can be a powerful solution. And so we've really shifted our approach, from a public enemy to a public health approach. But our laws and policies take a lot more time to follow. And so, we're in a big transition period, but and people are dying, and we've criminalized this disease, right? This isn't a surprise to anybody. The number of incarcerated people for drug offenses in the 1980s was 50,000. Today, it's about 500,000. That's a dramatic rise. It's 1,000% increase. We've used the criminal justice system to treat a disease. It's interesting. Recently, I was giving a talk at a correctional facility to their staff and the warden, and this is a jail in Pennsylvania. And he said to me, close to 90% of the people held in my jail suffered with a substance use disorder. That's massive. And he's like, I don't want them here. They don't belong here, which is really heartening to hear from a warden. So, I think change is starting to happen, but it's slow. This is a very busy slide, but if anybody wants a copy of these slides, it's a nice slide to look at some of the policies and addiction laws over time. It was created by the Recovery Research Institute at Harvard that does amazing work. But I would say, if you want to take a quick peek at this, in 2008 was really where things started to shift with the Mental Health Parity and Addiction Equity Act. Patrick Kennedy was working on that, where people with mental health issues and substance use disorders, insurance would cover that, where historically it didn't, right? We have no problem covering, physical ailments and other medical conditions. But when it comes to mental health and substance use disorders, we've really lagged. And that was a big shift. And obviously, the Affordable Care Act and CARA have instituted some excellent new policies, but we still have a long way to go. And if you're interested, I would take a look at this. You could even go to the Recovery Research Institute's site, which they have some amazing resources. And I just put this here. There's some, clips from some headlines, but there has been a big shift in federal and state drug policy around the country, around addiction, around building recovery capital and supports, trying to unravel some of these policies. But the reality is, we have a lot of work to do, and it is a large, complex web of policies that were developed over a long period of time. And this, I believe, is what's challenging our response to the overdose crisis. The overdose crisis isn't really about drugs. It's about our policy. Our policies have got us here, and our policies will take us out of here. But it's going to take some time. And this was just, I guess, a week ago or so. The White House put out a proclamation on Overdose Awareness Week, which is great. And there's a big shift, right? We've started to invest in harm reduction. We focused on the workplace, right? Because we know recovery capital, we know finding purpose, having meaning, having work where you can support your family. So many of these things are important in people recovering. And we're starting to focus on that, which is great. The elimination of racial disparities. Our policies has been rooted in racism for decades, for hundreds of years, really. There's a big shift there. The American Rescue Plan, almost $4 billion for the for improvements in the behavioral health infrastructure. and expanded access to medications. And I think most people on the call are aware of that. New laws around buprenorphine, methadone, and a number of other really exciting issues. And the reality is we've made a ton of progress, a lot of advances about, an understanding of the causes, the genetics, the environmental causes, trauma and the impacts, that fuel this disease. We've made a lot of progress when it comes to neurobiology, understanding the plasticity of the brain, neurotoxicity, the different pathways in and out of addiction. There's so much. Harm reduction has become front and center, which is a powerful strategy. The reality is, 90% of people don't access treatment. And what do we do? How do we protect the health and wellness of those people until they're ready, if they're ready? They may never be ready, but we should still support them because they're human beings and respect their dignity. Recovery science has really, advanced dramatically. We've come a long way, even the criminal justice system. And I don't think anybody should be treated for a disease in the justice system or a judge should be managing care. But that being said, there have been some amazing diversionary programs on the street, lead programs, drug courts, courts for veterans, struggling with substance use disorder. There have been a lot of advances, and there is will in some places, in many places. But despite that, more people continue to die. And, this is really frustrating. And I know probably everybody on the call sees this, knows this, feels that. I'm sure there's some direct service workers that see this day in and day out. And it's very frustrating. And I know as healthcare professionals, as physicians, nurses, recovery specialists, social workers, it is exhausting to see people cycling in and out and the suffering. And then COVID came along, right? And I think one of the dangers around COVID, COVID created the worst possible situation for people with substance use disorders. But one of the dangers is that I think many of us, or many people, in government are pointing their finger and saying, well, it's only getting worse because of COVID, but it was getting worse long before COVID, right? You can see the shape of that curve. Obviously, it has steepened over the past year or two, but we were not really making progress. And I think looking at overdose is a very narrow way to measure success, right? Nobody wants anybody to die. We'd love that number to be 0. But if we're just looking at overdose deaths and we're just trying to control drugs, that's not going to be enough. That's not going to get us out of here. And this actually I pulled from a presentation that Nora Volko did. And it just, during the pandemic, right, we've seen like changes in the drug supply, psychostimulants, press pills, it's constantly changing and morphing. And this is due to our policy, to our strategies, right? Overseas, many analogs are being developed daily, substances that have similar effects to, drugs we know well, but look different to evade detection, right? And so, these are things that have led to, the outcomes of our current strategy, which are we have an escalating public health crisis. We have failed to control or eliminate use. The harms have dramatically increased. Drug supply is, if you talk to the DEA or law enforcement, it is cheaper and more dangerous today than ever. Novel drugs are being developed left and right, increasing transmission and rates of disease, HIV, Hep C, Hep B, Hep A, endocarditis. A shopping list of things that we're seeing. And stigma, marginalization and discrimination is really no better. At least what I'm hearing, what I'm seeing, what I feel as a person in recovery, as a physician in recovery. This is really disheartening. And I think part of it is that, and I put this up here, this is from Health Outreach Partners, is that, and it's challenging because as as a healthcare professional, you're working on kind of the right of this diagram. You're looking at health outcomes, dealing with acute things day in and day out. And it's exhausting and really challenging. Maybe, at times you deal with some of the social determinants of health. I'm sure the recovery specialists on here are in that area, but we're all working in a system that isn't designed to deliver the best care, efficiently, practically, and it's not grounded in the realities of the idea that addiction's a disease, and that makes it really hard, right, when you're working in that structure. So how do you change those structures? And it'll take all of us, right? It's going to take at every level of this system to shape the system that we want, to shape the system to deliver the kind of care that every human being deserves. And so I want to jump into stigma because that's what we're really here about. But I think that gives you some context. And so what is stigma? And this is complicated. And the more I research it, and I've just started doing some pretty extensive research on stigma and talk to a lot of different experts in this area. And it's really complex. And if you're ever interested, Irving Goffman wrote this classic book called Stigma, Notes on the Management of Spoiled Identity. And it's very deep, but stigma is basically an attribute, behavior, or condition that is deeply discrediting. And it's not just that, but it's a language of relationships. So, a person that's stigmatized is constantly challenged, not just with themselves, but with every place they go, right? Every relationship they have. And that includes, and really importantly, the relationship they have with you as a healthcare professional and walking through that door, right? And it's something that I don't think we think about or talk about enough. And, historically, bodily signs, were used to expose something unusual or bad about the moral status of the signifier. Historically in Greece, signs were cut or burnt into the body to advertise the bearer as a slave, criminal, or traitor, a person polluted and to be avoided. And, we don't cut or burn things into people, but we label them today, right? We judge them, we shame them. And stigma is very complex. It's a multidimensional construct, and it really is a set of negative beliefs that we have about a group, society, people with a substance use disorder, people that have been impacted by the criminal justice system, which is a frequent occurrence with people that struggle with this disease. And this is a major cause of discrimination, right? Prejudice, abuse. We justify our abuse or mistreatment of others by this. And stigma is a public health crisis. And I think stigma is the public health crisis when it comes to the overdose crisis. And, there's a lot of angles to this, power, separation, status loss, and widespread discrimination. And that discrimination is not always overt. Sometimes, actually, a lot of times it's covert, and it's embedded in our systems. And we've been doing it for so long that we just accept it as okay, and it's not. Here are just some quick examples from the Legal Action Center on the unfair treatment of individuals. This list is long. I mean, this is just a snippet, but look, a young mother evicted from a shelter for taking prescribed methadone. I've heard of homeless shelters in the city of Philadelphia where people, if they're on Suboxone, are not allowed to stay there, right? A young man with alcohol use disorder cleared for work by a physician, but denied work by employer. And I put at the bottom here, stigma among health professionals towards patients with substance use disorder. But I would also add stigma towards health professionals towards their own, to doctors, nurses within the system. Our medical systems do this all day, every day, right? And that's why I say change has to come from the top. And I just wanted to throw this up here. It's no surprise, like aside from our policies, the media has played a huge role in this, right? And many of you have seen some of these pictures, but this has been imprinted in our minds over decades. So why does stigma matter? Individually, shame, guilt, and self-hatred, social isolation, disconnection. This causes people to hide to survive, really. And this is a barrier for people, asking for help. Nobody feels it's safe. And up here, the second line with the individual at the end, I put something called dislocation. And there's a social psychologist in Canada, his name is Bruce Alexander. I would recommend looking at his book, The Globalization of Addiction. But he talks about dislocation as this unbearable emptiness of people who have little to live for and lack a secure and meaningful place in their society and in the world. This is, psychological social disconnection. And this is many of our strategies disconnect people from society. That we marginalize them, we judge them, we shame them. And we do that in our healthcare systems too, right? And when we do that, we fuel addiction. We fuel addictive behavior. When you look at this, description of dislocation, lacking a secure and meaningful place in their society, in the world, I mean, that is really powerful. And, he wrote this: human beings only become addicted when they cannot find anything better to live for and when they desperately need to fill the emptiness that threatens to destroy them. And interestingly, this isn't just limited to people who are drug addicted. It afflicts many of us to a greater or lesser degree. And I think that's really interesting. And obviously, the consequences of stigma, in terms of society, discrimination, jobs, occupational licensing, housing, insurance, education. I mean, the list goes on. And this increases social distance, and we'll talk a little bit about social distance in a bit. And it fuels decreased support for effective public health policy, and increases support for punitive policy, which we know doesn't work. And in the healthcare professional system, right, we were trying to engage with this population, and this isolates and alienates them. The reality is nobody with a substance use disorder, nobody after overdose wants to go to the hospital. They don't. And so we have to change not just how we act, but how we think, and how we treat people with substance use disorders. Because this disease affects all of us. I mean, if we're really honest with ourselves, might not be you, might not be a family member, maybe it's a friend, maybe nobody but maybe you see it at work all day, every day. It is around us. And we can't sweep it under the rug any longer, And the reality is, when we disengage with this population, when we occasionally engage with them, we deliver low quality care, which leads to poor disease management, increases morbidity and mortality, and costs are astronomical. This, substance use disorders are costing this country close to $1 trillion a year. I mean, that is astronomical. And some of the solutions we have, even something like a syringe service program, education, naloxone distribution, medication-assisted treatment, some of these very simple, easy things, well, they should be easy to implement, can save us a fortune of money. So even if you don't care about people, it is a very expensive and costly disease. And, there's many types of stigma. I'll just, feel free to, refer to this. Some of the big ones, when it comes to the current crisis, are public stigma, perceived stigma, structural, which are, embedded in our systems, self-stigma, which I would say is probably the most painful. Well, I don't know if you can quantify it, but self-stigma is really painful. And stigma, from delivered by healthcare professionals. And interestingly, there was this study done by the World Health Organization that looked at the 18 most stigmatized conditions around the world. Drug use was number one, alcohol was number four. And, a lot of this, is related, and there's been studies on this, to cause and controllability, right? If we think somebody caused their own disease and they can control it, the stigma's off the charts, right? But other things, say heart disease or cancer that somebody has no control over, stigma is very low, not non-existent, but much lower. And it's interesting. And so I've been pretty obsessed, with stigma for quite a while, having, lived experience and, really trying to understand it. And I know there's a lot of anti-stigma campaigns across the country, very well intentioned, but I was always kind of perplexed that like how are we measuring the effectiveness of these different campaigns? Are they working? Are they causing more harm? So I partnered with, my organization partnered with ProA, which many of you might know, the Pennsylvania Recovery Organization Alliance, Riwi, which is a data company based in Canada, to look at drug use and recovery stigma. And the objectives are to collect, measure, and gain insights into perceived stigma, which is what we first looked at, and use data to drive effective messaging and education, improve policy and practice, and really create a better world for people who use drugs. I won't go into methodology, but it leverages the internet to capture random anonymous data, which is really interesting. So just last month or 2 months ago, June to July, we deployed this survey, which was a 26-question survey, to over 26,000 Americans. We had 4,484 completions, but there's some drop off. So actually some questions we had upwards of 11,000 people answer. And we weighted it in terms of age, gender, and state population. We managed to get respondents from people all over the country. You can see in every state. You can say Pennsylvania there was a very large sample size because we oversampled Pennsylvania. And I'm not going to present that data today because we really wanted to understand what's happening in this state. And I also had the idea of creating a stigma index where we could track it over time, measuring the questions measure different components of stigma, which was really kind of interesting. We also did ask a few recovery questions. We really got a diverse set of respondents from across the country. You can see, based on gender, age, also race. But I just want to run you through these. We asked some different questions. Imagine a person who uses drugs or alcohol problematically. Do most people view this person as a member of their community? So 71% of our sample believe that society at large considers those who use drugs problematically to be outcasts or non-members. We looked at lack of willpower. 73% believe that others view drug use as somewhat, mostly, or completely due to lack of willpower. And we could talk for hours on the different associations with what we found and how that impacts how we deliver care, how we see people who use drugs, our understanding of the disease model. Willpower has nothing to do with it, right? To what extent does society believe this person can improve their situation? So 70% believe we have a 50% chance of being unlikely or never being able to improve our condition. That's disturbing. 74% believe that most others view people who use drugs as somewhat, mostly, or entirely responsible for their drug use. 73%, somewhat fear or greatly fear people who use drugs, and that they'll behave unpredictably. And as viewed by society, can someone dependent on drugs or alcohol maintain recovery? 73% view people who use drugs as having a moderate, low, or no chance of maintaining recovery. And this was, I think this is the last one here, is a person who takes medication for their addiction considered to be in recovery. So 28% believe that others view people who take medication or their addiction as always in recovery. And I know I'm talking fast. We did have about 1,000 healthcare professionals opt into this study. About 300 completed it. And I'll just say, because we're looking at the data is worse than what I just presented here nationally, which isn't really a surprise. And so I just put some questions here, something to think about, like, what do you believe? How do your beliefs affect the care you deliver, right? What does your patient believe, right? How do they perceive you're going to see them? And how do their beliefs affect their interactions with you? I think these are really important questions. And ultimately, what can we do to improve engagement, care, and outcomes? And these are big conversations. I did put a few studies here. I know I'm getting close to the end of my time, so I'm just gonna move through them and get to kind of the end. But the reality is that healthcare professionals have high levels of stigmatizing attitudes. Even though we believe it's a chronic condition, we have a high desire for social distance. We don't really want to associate with these people. We don't want them in our hospitals. We don't want them in our neighborhoods. And this is a problem. And this might be hard to read, but I would just say, if you look at the bottom bar graph, believes about the treatability. So people with opioid use disorder can, with treatment, get well and return to productive lives. So these are physicians that were sampled, 92%, right? And then if you go to beliefs about causes, opioid use disorder is a chronic medical condition like diabetes. 77.6% believe it's a chronic condition. But if you look at the social distance attitudes at the top, it's disheartening, right? We don't want them married into our families. We don't want them as a neighbor. We don't want them anywhere near us, and that's a real problem. I would look at this source. This Jonathan Avery, who I believe is at Cornell, wrote this great book on the stigma of addiction. Here's some more data that basically, shows that over time through training, as medical professionals go through training, their attitudes towards people with substance use disorder really deteriorate. And they don't find them enjoyable to treat. They don't find them treatable, and they don't think we should put direct resources towards taking care of them. And ultimately, what does this all mean, right? Stigmatizing attitudes or perceptions are a major barrier to the delivery of quality care, limits the capacity for us to treat people, leads to poor quality treatment and low patient engagement, and leads to less support for policies that will improve things. And so what can we do? I'm just going to hit on a few things here. Education is important. A forum like this is important where we're talking about this, looking at our attitudes and beliefs. And I really think we need safe spaces as healthcare professionals, because the reality is healthcare professionals, and I know this because I work with another physician and run a physician support group online through the Live Well Foundation in Philadelphia. And I know, like, nobody's willing to share their struggles. Doctors, nurses, they are afraid of professional consequences. They are afraid of licensure issues, all valid concerns. But if we can't talk about it and we can't share these things, our workforce is suffering, and with the current crisis, that has escalated dramatically. And I've seen it in our groups that we run. So we need forums to discuss these issues, our own issues, and our beliefs around, treating this patient population. And we need everybody there, right? We need leaders there as well, that are not going to judge us, shame us, and stigmatize us. Storytelling is really powerful, but storytelling, the right story to the right audience at the right time can be really powerful and change things. But stories can also be harmful, right, and dangerous. And so it's a slippery slope. But we need more of this. And B Cares has this healthcare professionals opposing stigma, and it sounds like, oh, that's great. It's a bunch of professionals, sharing stories. That's a really powerful, a really powerful method to change things, because it is rare for a healthcare, and I know this because I was in the Physicians Health Program in Pennsylvania. The vast majority, I would say 99%, want to just do their time and get out. Nobody is sharing about their struggles, right? Nobody is open about their journey. Almost nobody. And so we think we're exceptional, right? That we don't suffer. Well, physicians and nurses suffer at higher rates than the regular population, but nobody's talking about it. So I think this is really important. The language we use is critically important. Person-centered, we have to stress effective treatment exists and recovery is expected, right? Most people recover. I think many of us see the most challenging cases over and over, and we don't think it's possible. The vast majority of people recover, and the vast majority of people recover without a 12-step program or going to treatment. And it's something we're not really aware of, right? And people in recovery, do powerful things, and really, are out there advocating and changing the world. Reducing social distance, we could talk about this for a while. I'll just hit on this briefly. Collaborating with people with lived experience, also having people in our institutions with lived experience working, right, in every facet from the top down, right? Not just, in a quote unquote, lowly position or where they're at a distance, but actually at the table making decisions, guiding policy and practices in our institutions. As I've mentioned before, administrative and clinical champions is critical and really important. We need allies, we need leadership. There's leadership everywhere. I mean, the longer I'm in recovery, the more I see it. There are people from every facet of society doing every kind of work, including, at high levels in the White House, right? That are doing amazing things. And advocacy, you as healthcare professionals, your voice is really critical and important, and people listen to you, and you can really be a powerful force for change. And so that was very quick. Here are some just, primers on language to use. Take a look at it. I just, this Be Cares program is amazing. I was looking at it last night, but I don't care how robust your program is or how incredible it is, unless we change our attitudes, like unless we really, look deep, and look at people that are struggling with disease as human beings and deserving of care. It doesn't matter, what strategy we have. We'll never be able to deliver the most effective strategy and make some, powerful change. And here's some, just some clips from some different initiatives that are going on. And that's it. I'm going to turn it over to Bonnie. I hope I didn't talk too much. Thanks so much.
Thank you very much, Sean.
Dr. Milas, we can't hear you. Are you speaking?
I am speaking. Can you hear me?
Can hear you now. It's a little bit in and out.
Okay. Just a moment. Just trying to get my slides up.
Okay.
I may have to, I can't get to, slideshow, perhaps. Can you see my slides?
Yes.
Okay. I'm just going to start from here at this point then.
Okay.
So,
Bonnie, I think in the upper left of your screen, there's a little arrow. I think that's the presentation. Go up just a little bit more.
Here?
The kind of red and to the right a bit. You see there's a little arrow up.
There.
Yep, I think.
Okay, great. Okay, very good. So as Sherry had already introduced me, I'm obviously a physician at the University of Pennsylvania, but I just wanted to share with you, the picture on the far left is me graduating from nursing school. So I've had a number of positions as a healthcare provider or within the healthcare system. So I have been at the bedside as a bedside nurse. I've been an intern, I've been a resident, and now as a professional, a staff physician, taking care of patients in the operating room, but also the ICU. Along the way, I got married, had 2 children, and subsequently lost both of my adult sons to opioid overdoses. I have been very outspoken about this, trying to advocate for those who are family members of those that suffer from substance use disorder. This piece here is in the USA Today. This was me talking about my experiences as a mother. This piece is from the Philadelphia Inquirer. I was talking about the need for individuals in the home to be 100% prepared to have naloxone on hand and also to have just basic life support skills. I've stood before an entire audience and told a story of really reviving my son with naloxone at this Narcan Story Slam. And the idea in mind is to change people's perception of a family that is dealing with substance use disorder. It's not entirely that group in Kensington or the marginalized person on the street corner who's injecting drugs. You know, Sean had pointed out that you might not want someone with substance use disorder being your neighbor, but our family, we were clearly neighbors of others. It's not just in Tullytown or in Levittown, it's in Doylestown. It's guaranteed. It's in your neighbor's home, if not in your own. It was mentioned that I do naloxone rescue training. I do this through the Bucks County Overdose Education group. I work with Rodney Millspaw and also David Falco, and we teach family members how to be prepared. I'm all about harm reduction. We do need to decrease overdose deaths. So we talk about, you found an overdose victim, you've called 911. Do you have any idea of what to do before the EMS or the police squad gets there? We talk about what happens when someone dies from an overdose. First of all, opioids are brain suppressants. It causes the breathing to slow and eventually stop. The brain's no longer getting oxygen, and eventually the heart stops too. And this is how someone dies due to opioids. So we talk about, if you can interrupt this process on the far left-hand side, sleepy, unconscious, and their breathing slows. If you can intervene at that point, that's how we can get individuals to survive with their brains intact. We talk about the fact that the time when you're calling 911, that's not the time to be practicing for the very first time. You want to think about being prepared, plan, and practice. This is a refrigerator magnet that we hand out at some of our Bucks County events. Mallory Parati and I put this together, and this is an encouragement for families to talk about the risk in their home, to have a code word, to have supplies immediately available, to talk about what your role would be in this circumstance. Not everybody knows how to do CPR or even wants to do it. So who's going to do what? Practice. Also, think about what would you do if you were in this circumstance by yourself. I always talk about having your cell phone on you, taking it out, using it on speaker mode, and that way you can tend to the victim and speak to the dispatcher at the same time. You also have a timestamp, so you know when you gave your naloxone and you can start timing doses. Critically important. So let's change gears and think about, as healthcare providers, Sean mentioned that we as healthcare providers, we sometimes promote our own understanding or lack of understanding, our own stigma. We put that on patients. So I want you to think about yourself as being a critical link. When these patients come in to the hospital or to the ED, these are critical touch points for that patient. You may be the only link if you extend yourself by means of conversation. So these are some real circumstances that I've heard about. So again, the patients are either in the ED or they're in the inpatient ward. So before the patient leaves AMA or leaves the ED after an overdose, naloxone is immediately available. It's immediately on hand. It could be given to the patient or a significant other, but it's not. Why not? So a few of the responses that I have heard is, why would I give naloxone to a patient with opioid use disorder? I don't hand out epinephrine pens to patients with bee sting allergies. So again, that's the type of response I'm hearing. Another response, why would I give them a drug that they cannot administer to themselves? Like, this is a stupid idea. So think about yourself as a healthcare giver. Could you change that narrative with conversation by saying, if we give that medication, or if that individual with opioid use disorder gives that Narcan to a friend or a loved one, or if it's in their pocket, it could be used to save their life. Another potential response, you're in a caring profession with a professional obligation to save lives. What does it say about withholding medication, free medication, or information? What does that say about you? Or perhaps maybe you'd feel more comfortable saying, what does that say about us if we withhold the medication or a link to service? Other things to think about, clinical initiatives, just things that you can do daily. Person first language. This was an initiative at the University of Pennsylvania. Sean has already mentioned this, but rather than referring to people by labeling them with their clinical condition, rather than saying the drug addict in bed 10, you could say, Mr. Smith, who suffers from substance use disorder, is in bed 10. So these are how we can communicate with other healthcare professionals. I'm going to just go through these next 3 slides very quickly. Myself as an anesthesiologist, and you can do this too, even as a bedside nurse, without the family being around, is have what I call a use conversation. So you talk to them about, what do you use to help you relax when you're at home? Going through a list of benzodiazepines, then perhaps opioids. I try to normalize this conversation by saying many of my patients suffer from chronic back pain or neck pain. They need to take Percocet. What do you use? And then I also take them through a conversation about also recreational use. But this allows us to clinically plan, to manage dependency, or lower the risk of withdrawal. And also, I and you can be a link to recovery or treatment services. B-Cares is immediately available. It's not going to be used if you don't hand them the brochure and you don't bring up the topic for discussion. So again, conversation is key. Next, I'm going to just play, this is a video, this is me in a TED style talk that I did for my professional society. I will play it and then interrupt it. Points.
Dr. Milas, I don't know that we can hear this video. Can you turn it on your end? No, we're not able to hear it.
Okay. Is Bethany able to just play it from her end, or we can just stop?
Bethany is having computer issues right now.
Okay.
So what I'll suggest, Dr. Milas, is that we send this video, the entire video, out to everybody who attended so that they can view it on their own.
Okay. What I can do is, let me just, I will just briefly describe what I told in detail. I described how I found my son down in the dark. I had to give him Naloxone to revive him, and the police and EMS arrived. The police were a bit dismissive with me. They joked among themselves that they had been at my house before. And the EMS individual asked me to keep my voice down because I was quite upset with my son and the circumstances. She turned around and said to me, "Ma'am, can you please keep your voice down? I'm trying to do my job here." The other situation that I had described was how I was at a supermarket handing out naloxone, and a woman approached and she said that she did not need naloxone because she taught her children right from wrong. And if somebody died due to a drug overdose, then, basically, so what? They died. So she didn't want to have any part of naloxone or anything that we had to say. So that's just a brief summary of the stigma that I had been exposed to as a family member, as a loving family member dealing with a stressful circumstance. So I will now just take you to the last slide, which is I am, again, very involved in harm reduction. Through my professional society, the revivedmecom is a website that anyone in the audience can refer a patient to. I encourage you to go, you can Google search it, it immediately pops up. There is, first of all, there is the entire discussion. My TED talk is there. You can look at it in its entirety. More importantly, there is an infographic that any family member can download. It teaches them the very basic, bare bones of what they need to know, how to recognize an overdose, what to do, how to respond, how to save a life, and also where you can get naloxone. And the other thing that is available is a slide set that if anyone in the audience, a healthcare provider, wants to do a community brief presentation or in their own hospital setting, that they can download that slide set. So I'm going to bring this to a close now, and I'd like to open it up for anyone in the audience who has questions for Sean and myself. But thank you very much for having me.
Thank you, Dr. Milas and Dr. Fogler, for those wonderful presentations. And Dr. Milas, for you revealing some of your family's story. I know that's not easy, so we thank you for that. We don't have any questions in the chat at this time. So does anybody want to unmute yourself to ask a question? Okay, well, we do have a couple of minutes left. So Dr. Fogler, I'm going to ask you if you can talk about some ways that you felt stigmatized when you were actively using, and how maybe those situations could have gone better or resulted in a better outcome for you at that moment.
It's a really interesting question, and my answer might not seem obvious. You know what? I never felt that it was safe to ask for help. So, my strategy, and I don't know if it was intentional or subconscious, was just to hide, to hide, to survive. And I don't, though I would hear my colleagues occasionally say somebody came into the ER, who had a substance use disorder, or somebody who we had seen over and over again with abscesses, coming to the OR to have an abscess drained. I would hear comments. I don't think I internalized them. I think I was very disconnected. I don't think I really felt that I had a problem. I just operated, and I wasn't using substances that were available at work. So in my mind, I was like, that'll keep me safe. Obviously, that's a horrible strategy. But I didn't. And the stigma, the real stigma, was, once I was in recovery, that's when I started to notice it. And the reality is I got into recovery in 2015 voluntarily. I went away to treatment for 4 months, totally changed my life. I practiced anesthesia in the Philadelphia area as well. I went back to practicing anesthesia, and about 6 months into practicing, I decided, because of my experience, to do a fellowship in addiction medicine. And so I started a fellowship in addiction medicine up at Caron. I was about a month into the fellowship. And that was when I was arrested for writing, some prescriptions when I was, in active substance use. I was about 1.5 years into recovery, and I was completely confused, why is this happening now? I feel like I've climbed Everest. Recovery was hard, but recovery was is an amazing thing. And it was really, when I was criminalized that I felt massive, obviously, stigma, not just, professionally, but personally. And, a doctor with a substance use disorder that, is criminalized, and in the paper is demonized, right? And, that's, that's it. So, and I've been in recovery almost 7 years now. That process was really traumatic, and like I mentioned earlier, like my substance use disorder really started after 9/11. I was at ground zero during the attacks, and like as traumatic and painful as that was, the criminalization, there is nothing more painful and destructive. The criminal justice system does everything. And I work with law enforcement, so it's interesting I'm talking openly like this, but the criminal justice system does nothing helpful for the disease of addiction. And I'm not saying people shouldn't be held accountable for their actions. I'm just saying the general strategy is extraordinarily destructive. And until we address that, progress will be very elusive.
Thank you, Dr. Fogler. And I know that we are over time, but there was a question in the chat for Dr. Milas. Is there something we can say to family members who have lost a loved one to be supported other than how are you really doing, which tends not to be useful? And Dr. Milas, do you want to talk about that for just a moment? And then we'll have to end because we are a little bit over time.
Sure, I did answer or reply in the chat. I think what I have always found to be very impersonal is someone saying, sorry for your loss. It is impersonal. It doesn't really acknowledge who the individual was and how painful that was. So I usually like to say that must be very painful, the loss of your dear son, your daughter. Sometimes that helps to maybe open the door and give them the opportunity to talk if they want to. Sometimes they're not ready to even acknowledge it.
Thank you very much. And I think that's a good place for us to end. I hope that you've all gotten some, new perspectives on seeing individuals with substance use disorders and helping them in any way you can to get into treatment or with support, education, whatever it may be. If anybody has any questions for me about CE credits, please feel free to contact me. We are recording this video and we will send the recording out to everyone. Also, I wanted to mention that we do have those refrigerator magnets that Dr. Milas and Mallory and Bethany worked on. And so if any of your agencies or hospitals would like some, please be in touch. And that's the end of our presentation. Thank you so much, Dr. Fogler and Dr. Milas.
You're welcome. Thank you.
Thanks.